next few minutes, I will introduce our research about the umbilical cord and its effect on perinatal health. My name is Gréta. Currently, I'm a second-year PhD student, and I'm working at Heim National Pediatric Institute. My vision is to improve the quality of life and extend the life expectancy of newborns. To achieve that, understanding the impact of umbilical cord coiling and management on perinatal health is my mission. Now let me introduce our two ongoing projects and specific goals to achieve this mission. The first one is about the umbilical cord management in neonatal resuscitation, and the second one is about the umbilical cord coiling index. So let's get to know more about the first project. According to the guidelines based on the ICOR recommendations for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with improved translational circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. Most newborns breathe spontaneously after birth, but around 15% require some degree of active resuscitation. The need is inversely related to the gestational age, so for example, for the very preterm infants, it is approximately 85%. Unfortunately, for these preterm and term infants, we have insufficient evidence on the optimal time of cord clamping. So our aim was to determine whether intact cord provides physiological, neonatal mortality, morbidity benefits for infants requiring resuscitation. During our research, we examined how starting resuscitation before and after cord clamping affect the neonatal outcomes, and we hypothesized that the intact cord resuscitation is a safe delivery room stabilization management, and it improves the neonatal outcomes. We conducted a systematic search with this search key of 2 domains, and it resulted around 18,000 hits. After the selection processes, we had 12 eligible articles for the systematic review and 6 RCTs for the quantitative analysis. Now, let me show you our main results. As I already mentioned, we used only the RCTs for the quantitative analysis. For effect measure, in case of dichotomous outcomes, we used the risk ratio. If the risk ratio is 1, it means there is no difference between the effects of the two groups. If the risk ratio is above 1, then the event is more common in the intervention group, which is the intact cord resuscitation group. If it's above 1, then the event is more common in the control group, which is the cord clamping prior to resuscitation group. In our study, no statistically significant differences were found in terms of in-hospital mortality, temperature at NICU admission, delivery room parameters, and early complications of the prematurity. However, in some of the examined outcomes, we found the following findings, which can be interesting, but further research is needed. Here you can see the analysis for the oxygen saturation level at 5 and 10 minutes after birth. The mean differences suggest that in the intact cord resuscitation group, the mean oxygen saturation level was higher with 6.67% at 5 minutes and with 2.87% at 10 minutes after birth. On the following plots, I will show the risk for different early complications of the prematurity. Here you can see the overall risk ratio for all grades of IVH is 1.25, while for the severe IVH it is 0.96. If we analyzed only those studies where they used special resuscitation trolley, we see the overall risk ratio is 0.75 in case of severe IVH. The next outcome is the necrotizing enterocolitis higher than stage 2. The overall risk ratio is 2.05, and if we examined only those studies where they performed delayed cord clamping in the control group and not early cord clamping, the risk ratio is 2.89. And if we analyze only those where they used special resuscitation trolley, the overall risk ratio is 1.22. Lastly, the analysis for retinopathy of the prematurity requiring treatment resulted in a risk ratio of 1.60. To summarize our results, we can see none of them reached the significance level. And the reasons for that can be the small sample sizes and event numbers, the different definitions of the outcomes, the heterogeneous protocol of the interventions, and the various resuscitation platforms. Considering our research, it has some strengths as well. We included only the RCTs in the meta-analysis to achieve a higher quality of evidence. We examined preterm and term infants also. We had 17 analyzed outcomes and detailed subgroup analysis. In conclusion, we can say intact cord resuscitation appears to be safe, and it may improve initial oxygenation, although it is in conflict with the current standards for the delivery room management. The early complications of the prematurity remain unclear, so the application of the intact cord resuscitation for preterm infants should be performed with caution, and we recommend to perform it only in specialized centers with appropriate expertise, protocols, and equipment. And also that the use of specialized resuscitation trolleys seem promising to reduce the risk of IVH and neck. As there is still no clear and strong evidence for the optimal cord management during neonatal resuscitation, we suggest to conduct further high-quality RCTs with larger sample sizes, standardized intervention protocols, and outcome definitions, and it is essential to differentiate outcome data between infants requiring post-birth stabilization measures and those not requiring them. We have already submitted our manuscript to the Journal of Pediatric Research, and it is under review currently. In the last couple of minutes, I would like to say some words about our second project as well, which is about investigating the association between umbilical cord coiling index and perinatal outcomes. The coiling of the umbilical cord is the coiling or twisting of the vessels within the umbilical cord in a regular helical pattern, and it is assessed by calculating the umbilical coiling index sonographically during the antenatal follow-up or postnatally. Intrinsic developmental abnormalities have an effect on the coiling of the umbilical cord as well as the early fetal movements as well. So they can lead to hypo or hypercoiled umbilical cords. We know that the alteration in the umbilical cord blood flow can cause physiological changes in the newborn infant. So believe that the hypo and hypercoiled umbilical cords can lead to perinatal pathologies. So our aim is to evaluate the association between abnormal umbilical cord coiling and adverse perinatal outcomes, and to find out if the UCI is a reliable antenatal biomarker. And we hypothesize that abnormal degree of the umbilical cord coiling is associated with adverse perinatal outcomes. We hypothesize that the UCI is a reliable antenatal biomarker for the perinatal pathologies, and that the degree of the coiling does not change after the first trimester. Here you can see a short summary of my previously described projects. We submitted the first one in May this year, and about the second one, we finished the preliminary search, and we are currently at the phase of the Prospero registration, and we are planning to submit it at the end of this year. So in the last 1 minute, I would like to say some words about my additional scientific activities as well. Last year, I had a presentation at FINETA conference about the effect of delayed umbilical cord clamping on the adaptation of preterm infants born at 34th and 35th weeks of gestation. And next month, I will present my first topic in Ljubljana. And now I would like to finish my presentation with one of my favorite quotes by Gréta, which is, "There are two types of people who will tell you that you cannot make a difference in this world, those who are afraid to try and those who are afraid you will succeed." Thank you for your attention.
Do you know the regulation about cord clamping time? What's the protocol? How many minutes?
Yes, resuscitation protocols recommend to wait at least 30 seconds, but ideally we should clamp the cord after the lung aeration happened.
And one more question. Do you know anything about how much is the occurrence rate in Hungary regarding using delayed cord clamping in the NICUs? Just a guess. How many percentage? What do you think?
Yes, as I heard, based on the data from 2021 or 22, it didn't reach the 40%, unfortunately.
Is there a meta-analysis on this topic? It was quite a new topic for me.
Yeah, we have just finished the preliminary research, and I found one meta-analysis from 2019. And
what was the result?
The result? They had around, as I remember, 26 articles in the meta-analysis, and they found an association between the hypo and hypercoiled umbilical cords and perinatal pathologies like fetal anomalies and heart rate abnormalities, small for gestational age, large for gestational age, and these complications. But they also brought down that further research is needed about the assessment of the UCI, the index, because it would be useful if we know already at the phase of the antenatal follow-up. So we should decide when to assess this index, and also about the measurement, for example, to measure it from the whole length of the umbilical cord, or just like one part of the umbilical cord, like 10 centimeters. These are not clear yet.
Congratulations for presentation. I am not a pediatrician, so sorry if I didn't get something right, but regarding the first project, how homogeneous were the population? Do you have any data about it regarding the time of birth? I'm not sure, were they all preterm babies or?
We examined both preterms and terms also.
Mm-hmm.
We just had 6 RCTs, and we had 5 with the preterms and 1 with the terms, examining these, and we had subgroup analysis based on these 2, but for example, we couldn't for the terms. So we just had subgroup analysis for the preterm infants. It wasn't homogeneous.
Yeah, because on the introduction slides you showed that it really depends on the time of, on the amount, how much preterm a baby is, because after the 28 weeks, the risk is much higher than later on. So, but then you had no data about this.
Ah, yeah.
Already.
Okay.
Some stratification or something.
About the studies where they examined the preterm infants, it was like homogeneous. It wasn't like late preterms versus very preterms. It was comparable between them, and of course, because they were randomized control trials, also between the arms, it wasn't heterogeneous. So the baseline characteristics were the same for them.
Was this result, although nothing was significant, but the numeric data, was there a disappointment for you? Because currently there is we are very enthusiastic regarding late cord clamping. Zsuzsa is priest of this, so like religious feelings towards cord clamping, late or physiologic cord clamping. Was it? Or what could be the reason that higher rate, non-significant, but okay, these are numbers, not even a tendency to reduce the IVH, neck, and very serious diseases. What is the reason? What is the...
Yes, we were a little disappointed too. because we didn't expect these results. But of course, as you said too, these are not statistically significant, and the even numbers are very low. Sometimes it's even 0, and the total sample size is very small too. One reason that we were thinking about maybe the oxygen saturation. Yeah, it was higher. It was higher in the intact-core resuscitation group, but maybe it's the necrotizing enterocolitis can be associated with that one, with the higher oxygen level, the hyperoxia and the free radicals, maybe. But further research is needed.
Oh, was this paper already sent?
Our?
Yeah.
Yes.
Oh my God. Okay. So what is the so there were a lot of such studies. Why so low number is the studies in this? What were the selection criteria?
The selection?
Selection criteria for what kind of paper were selected to this review?
The main selection criteria was that when we were selecting and reading the full text, we could decide if all or almost all of the infants received resuscitation, like any type.
Oh, great! So this was cord blood cord during resuscitation. So cord clamping or open cord during resuscitation. This
yes.
was. Okay.
Yes, that's the intervention group.
So what is the conclusions? Because probably this is not so emphasized. Therefore, is so low is the number, because late cord clamping is a very generally used procedure since 10 years, and this is why. Okay, conclusion. ICR. Safe delivery room stability management and may improve initial oxygenation. The early complications of premature remain unclear. The use of seems. Okay. It's very important. What does it mean, resuscitation? So, because without a trolley, without a specific device, it is impossible to start a complete resuscitation.
We called resuscitation anything like further or more complex than just warming and stimulating.
Great. Okay. So, and in those 2 or 3 studies where there were no specific trolley for it, is there any detailed description how they performed the resuscitation without such a specific trolley and warming, how they warmed the baby with intact cord, and where did you place the baby, to the body of the mother or to the a specific table or?
In some articles, yes. In some, no. They just wrote down that it was with intact cord, the starting of any part of the resuscitation, like anything that is not the stimulating and warming, and not really further.
Okay. So we are believer, unfortunately. Okay.
Yes, thank you. Very much food for thought. I would like to ask about your conclusion. Preterm ICR should be performed only in specialized centers. What would be a specialized center in this context, and what should be done elsewhere?
We meant with appropriate expertise, protocols, and equipment. Like not just in a hospital where they usually don't handle preterms, but in more professional centers. who have protocol for this intact cord resuscitation, and also the equipment, like for example the specialized resuscitation trolleys like the Concord and Inspire and LifeStart.
May I join to this question a little bit more directly? Do you think theoretically that the steps of the algorithm of the resuscitation will change in case of intact cord compared to clamped cord? So this is a very rigid algorithm what to do. Every 30 seconds you should check the heart rate and the spontaneous breathing. And in some cases, when there is saturation, the saturation. So do you think probably intact cord resuscitation for 4 or 5 minutes long, when the cord is open, then this situation probably in the future results another algorithm for resuscitation?
In my opinion, no, because we need to check and do what we already did previously too, but it will be easier because, for example, when we have the trolleys, we have everything together, the warming device, the respiratory support, and we just wait with the cord clamping, and then we can do everything for the baby, and we don't need to wait, we don't need to move from the mother, but we can do everything there.
Based on the evidence that's concerning the babies not needing resuscitation, comparing the delayed or early cord clamping, what did you expect? Which outcomes will be beneficial for the delayed cord clamping in your study? Like, or maybe if you will have more RCTs in the future to analyze, what do you expect? Like, what do you imagine to be an evidence? It's a very strange question, I know. Sorry, but would be a logical event in this case.
I hope I understand well.
Sorry.
If we have more RCTs, what I expect based on the babies who do not need resuscitation, right? I hope and I believe that the early complications of the prematurity, like the IVH, neck, ROP, the risk will be lower for those babies, and the delivery room parameters will be better because of the oxygen saturation that we can provide, the respiratory support immediately, the Apgar score, the heart rate will be lower.
There is a quite fresh paper. I don't know whether this is an RCT or a systematic review on if the cord clamping time is more than 2 minutes, then IVH and a lot of neonatal outcomes are much better. Is this an RCT or is this a
systematic review and network meta-analysis?
Okay, and this systematic review which concluded this 2 minutes long, what is the difference of yours systematic review and so this meta-analysis and the these appear or published very recently?
They didn't separate the babies who didn't need resuscitation and those who did. So they didn't have separate analysis for the intact cord resuscitation for those.
Okay, they had a lot of baby who did not need resuscitation, just so spontaneous ventilation was okay in a lot of babies. Okay, thank you.